So welcome to the webinar, Scanning for Denture Success. The lecture is being presented by Jimmy Stegall, CDT, and we're going to begin shortly. And with that, it is my honor to welcome back Jimmy Stegall, CDT, a dental industry operational management and technical guru with 4 decades of experience. Jimmy is also a clinical educator, trainer, and published author. His impressive career includes 35 years growing and leading a major dental lab in the Southeast. And in the past 7 years, he has presented more than 460 educational and training events on implant and prosthetic restorations. Recently, the National Association of Dental Laboratories recognized Jimmy as their 2024 Excellence in Education Award winner. And his expertise as a thought leader, educator, and mentor has helped to advance cutting-edge digital techniques in dental practices and laboratories across North America. And with that, I get to say, take it away, Jimmy.
Jessica, always a pleasure to be with you. So one of my favorite topics, talking about digital dentures and dialing in the scanning steps. So part of Jessica's requirement to make sure that the CE credits are valid. I am being paid by them and happy to be here. All right. So scanners. People ask me all the time, which scanner should I buy? I tell you, I've tried most all of these and I can make all of them work. I think scanners today, the technology has advanced so well that with the exception of maybe a couple, I don't think you can go wrong with any of them. And so the goal should be, what works best in your hand, which interface suits you and your practice better. But as far as denture workflow is concerned, the 3 major guys, right? The Prime Scan, the Trios, the Itero, all do a good job. But I see a lot of Medits being used successfully as well. And the Shining is coming as an up and comer, but you can't go wrong with today's technology. And let's talk about digital dentures, for a second, and what they might mean and why we might want to do them. And I say this all the time: a digital denture is not really a new product. It's a denture, right? And I imagine that if we all could magically start making them all digitally today, tomorrow, you really wouldn't notice a difference. And so I don't think it's about saying I want to do a digital denture. It's about I want to do a digital denture workflow, because we have the processes, we have the materials, we have the equipment today to make a denture better than we used to make with acrylic. And when you look at them, you really can't tell the difference. A well-made digital denture looks as good or better than any traditional denture that I've ever done. And I come from a lab that did 100 dentures a day. So I've got a lot of experience of doing dentures. And I had one of my roles was to be a chairside support guy. So I saw all the nuances of what went on your side of the fence. And I feel certain that if I could go back in time and do them all digitally, that my clients would be happier. And I think the biggest reason by far is the fit. A digital denture is going to fit better. And I don't care if it's milled or printed. If it's a good system, a good equipment, and good material in the printer, in the mill, we're going to get the same benefit. But the big difference is we're telling a computer to make part A, the intaglio of this denture, fit part B, the tissue, to exactly the amount of space that we want for a denture. And, a denture stays in, we use the term suction, but it's really adhesion, cohesion, drop of water, 2 pieces of glass kind of dynamic. But in order for that dynamic to work well, you have to have the right amount of space for that drop of water or saliva. And in most research, it tells us that's around 110 microns. So when I tell a computer, make this denture fit exactly 100 microns away from the tissue, every square millimeter of the intaglio surface, that's what the computer does, right? It's computer, zeros and ones. Then all I need is a printer or mill and materials that can reproduce that design. And we have all that. So without a doubt, every clinical trial that I helped with Dentsply, all the chairside appointments I've seen with digital dentures, almost to the very last one, the patient and the dentist both notice the fit of these dentures when it's their first one. So we get that through technology, and that's the biggest win for you, because that's the biggest complaint and the biggest causer of all our problems. The next biggest win for you is having that record on file. Anything goes wrong, south, lose it, drop it, break it, want a new one 2, 3, 5, 8 years from now. There's a file exists, right, at the lab. And all you got to do is call and say, hey, I need it. I need a replacement. She broke it. Or she's been wearing it for 10 years and it's worn out. It's not pretty anymore. So she'd like it just like that again. Yeah, the lab will tell you to take a wash impression and scan it and send it to them, and we'll pull the old file and match them up. And so those are your key benefits. The net result is we're going to do this in fewer appointments. And this is growing rapidly, guys. Now, this is the way, unfortunately, that I would say I'm going to give it a generous estimate. 80% of the labs out there are still doing it this way. And somewhere there's some combinations. A lot of labs are doing this and moving into digital. But somebody's gone fully digital, very small percentage of labs. But about 20% are doing at least some digital now. So, but this is the way we learned, right? This is the way it's always done. And this is great. And we all know how to do this. And we know that we've made this work over the years. But this process, all the things you see here, are fraught with areas that can go wrong, right? Expansion, contraction, heat, temperature, long-term cure, all that stuff results in a product that we can't make fit to 100 microns 100% of the time. It's very rare that we do get 100 micron fit with the acrylic processed denture, whether it's press packed or even injection processed. And it's just impossible with all the variables and the material itself with the 6 to 8% shrinkage. So well, we've dealt with that forever, right? And that's why patients' number one complaint is, I wish it stayed in better. That's why denture adhesive is the number one thing out there on the consumer market. But when you take a digital workflow, and a digital workflow can be as easy as, doctor, you don't have to take anything. Send me a traditional impression and bite, and I will digitize it. And from that point forward, right, when we digitize it in the lab, everything else is digital, and you gain the advantages of that fit and great materials and all that. So a digital denture is easy to move into without any changes. But obviously, you guys are here tonight because we want to move some of that digital technology into the operatory and take advantage of what it can do for us to even speed things along further. But we're just making them different. It's not that we are not dental technicians anymore, or we're replacing dental technicians. We're just using a different set of tools. That's all. I still need to know what a retromolar pad is and how to move teeth where I want teeth and all those things. The technology just makes it easier. So we're making dentures today by creating them in a computer and then sending them over to a printer, printing bases, printing teeth, or milling bases, printing teeth, or printing bases, milling teeth, any combination that we might want to place in our workflows. And it's faster, it's more efficient, and the materials are stronger, and they look just as good. So it's really a no-brainer. On top of all of that, these workflows, these processes in a dental lab are pretty easy to teach. Most of them, right? I still need a designer that understands everything, but teaching somebody to operate a printer and to assemble the parts, it's pretty easy. And that's the biggest challenge lab folks have today, is finding skilled dental technicians. If I open up a lab tomorrow and start looking for tooth setters, it may take me a year to find them because we're not making them educationally anymore. The military is not making them. And so it's a real crisis in the dental lab industry of finding skilled dental technicians. But it is digital, right? We're designing, we're milling. And again, I don't have a problem with milling. A mill denture is nothing more than traditional acrylic, right? These pucks are pink acrylic that we've always used, but pre-processed. If they're pre-processed and I'm using a burr to cut the denture out, then I'm not having any shrinkage. That means that's a digital denture and it's going to fit wonderfully. And so familiar materials, we know what they are. The only problem with milled dentures is that they take longer. This is a reductive technology in manufacturing terms, meaning we start with a puck and we cut it down to a denture. And that takes time, and that's a lot of waste, right? Everything we cut out is just dust. So it's a more expensive process typically. The material costs we could learn to manage, I think, but the time, the best technology out there takes about 2.5 hours to mill a denture. And we can print 20 in 2 hours on a printer. But there's nothing wrong with these things. There's a place for everything. And I've always been a fan. This is where we all started in digital denture, is doing milled. But again, it's slow and it takes time, and you have to have enough milling machines or time to do it. And It typically means the cost is up there. We all felt like we'd be printing everything one day. And when the first printed denture came out, we called it Gen 1 resins. We were thrilled, right? We just went way up, way down in speed, right? We got faster. We could do it a whole lot faster. We could do more units at a time. We still had the same file, just we just didn't mill it this time. We printed it, so the accuracy was there. One advantage printing will give us is a deep undercut. In a milled denture, um, if there's a deep undercut under the flange, some milling machines can't get at it, even if a 5-axis mill, because of the depth of the undercut, and it will what's called burr compensation or overcompensate, and it'll have to mill out a little bit more above the undercut to get down to it. So that is one physical drawback to milled. Advantage to the printed is that it prints all undercuts. So the Gen 1 resins were great. Low cost, very fast, very accurate, but they were bad in that they didn't look very good and they were not very strong. These were very brittle, very fragile. They were not validated as a permanent restoration and still aren't today, but they have their place, a temporary, provisional, a trial denture, anything like that, and they're fine for that. Gen 2 resins is when the game really changed. Gen 2 resins brought us the strength, the aesthetics, the durability, the validations that we needed for a permanent restoration, a permanent denture. And it got really exciting then. And the technology started with certain printers, certain materials, but various options out there today. This is the system that National Dentex uses. And it's the first Gen 2. It's the one that's completely FDA validated. It's the one that has all the shades and colors and all the options for whatever type of tooth you might want to do. Maybe you want a milled tooth because you like milled PMMA better than printed. Maybe you want a carded tooth. They have all those options. And I'm going to explain the Lucitone base, but you can think of this with just about any of the Gen 2 denture based materials currently. There's some that are better than others, but the top tier stuff. These are polymer resins. They're not acrylic, so it's a different chemistry. And what that brings to the table is a whole new band of strength numbers. When we talk about strength in denture bases, right, I want to know what it takes to break this thing, right? If I want to bend this maxillary denture until I can split it into, maxillary midline fractures. That's where they all break. What is that number? Well, there's not an FDA number for that. There is a manufacturing standard for that, and it's called the ISO high impact standard. It is a very specified test that manufacturers can do on their denture bases to determine what that number is. And if that number is 900 joules per meter squared or higher, they're allowed to call it an ISO high impact denture base. And all the acrylics that we've done forever are around 1,000. The mill denture came out about 1,500. When this product was validated at Boston University, the first test right out of the curing oven was at 1,500, and everybody's excited, right? Now we have a printed denture that's just as strong as what currently was the best, which was that mill denture. But the FDA that says, now, wait a minute, if you're going to get FDA validation, you got to do some more testing, including, how does that strength hold up in the mouth? The high impact standard doesn't require mouth temperature. You do it at room temperature. But of course, we know they're wearing them. So Boston heats it up to 98.6, puts it back in the Instron, and it didn't break until 3,000 joules per meter squared. It literally got 2 times stronger in the mouth than it did outside of the mouth. The worst in all their hundreds of tests after that was about 2,000. So we can safely say through independent FDA validation testing that these polymer printed bases are 2 to 3 times stronger than any acrylic we've ever done. So that's a comfort, right? And so, rednecks like me, we're going to go test them the way we want to test them. So we take them out in the parking lot and run over them with the truck a couple of times to see what happens. And this one don't break very often, guys. Now, nothing's unbreakable. You give us a minute, we'll break it, but they don't break very often. Most patients don't complain about them being run over, right? Most of them drop them. So it's a fun thing to do is throw dentures in sinks just to see what happens. And they bounce a lot. It's what polymers do. So pretty exciting to have this strength. Now, in my lab, about once a month, we'd send a new case out the door. Patient would take it home, and everybody already knows the dog finds it, right? So we've been letting Max test them for a few years, and probably not a good test. My granddaddy would say, nah, not a good test because that's not a real dog. So we have that. Here we are in the Instron machine, and you can see this denture is going to go a long way before it breaks. An acrylic denture is going to break in the first few millimeters of that test. And it's acrylic's brittle. We know that. That's not a bad thing. It's just different, right? Polymers are going to bend more before they break. And that gives us a lot of comfort for knowing that we're going to have fewer repairs. And yes, it's repairable. Easy to use in the lab, good shades. And again, like I said earlier, we've got all kind of tooth options, whether it's milled or printed. And it's nice to know we have the strength in the teeth now as well. So this particular tooth resin matches the strongest carded tooth out there. So we're not worried about these wearing away. And they come in all 16 Vita shades. So we're making dentures, again, either printing or milling bases, printing or milling teeth, using these really cool libraries that make this product look better. And we're getting dentures that are 2 to 3 times stronger than anything we've ever done. So I'm a fan and see, no reason not to do this. One of the questions I'll get often is, how do you put the teeth in? And the chemistry, every manufacturer is different, but we're really literally fusing teeth to base. I've been trying for 7 years to get teeth out, whether it's pliers or breaking them or whatever. And I did a video for Instagram not too long ago, and I was literally trying to break teeth on camera. And I had every one was a cohesive failure. I broke the tooth from the tooth and no adhesive failures. And I've not seen one. And so the chemistry, whatever sorcery these guys are coming up with to bond these teeth in, I think that's a phone call we're going to receive less and less of over the next years as we move into this. The bonding, we just don't have tooth pop out. So that's why you want to do it, right? All that's good. Let's talk about how we're going to do it. And again, I don't necessarily have an affinity to one denture material over another or printing over milling. To me, it's all about the workflow. To me, it's all about changing our lives in the denture treatment. Every lecture I've done in the last 5 to 8 years, I've always asked the question, what's your favorite thing about doing dentures? And the answer is always the same. The number one answer is nothing. And I get it. There are some people out there that like to take bite rims, but most of us don't. And remember, I come from a lab that did 100 a day. So I was in a lot of appointments. And so I feel your pain. I see it. And why do we like it? Well, it's hard. I get it. Taking a bite rim bite is extremely challenging. Custom tray border molding is not an easy process. Wax try-ins, all those things. So if there's something we can do, right, to improve those things or make those things easier or reduce them or compress them into fewer appointments, right, I think we're going to win. And the digital denture workflow is going to give you that, right? I promise you, when you're through with this, you're going to say, like I said the first time, the record taking is easier. The record taking is going to go faster. The try-in appointment is going to be very minimal. Post-delivery adjustments are going to be minimal because of the technology. And hey, if they lose them, we're not worried because we just call the lab and say, print another one. So it's better. But this is what we all learned, right? This is a conventional denture process. And I always look at the dentist column and think about, yeah, that's what I was taught, right? I was supposed to help the dentist get through 5 appointments, and that denture is delivered on the 5th. Again, 100 dentures a day, I can promise you not many of them happen that way. Visit 4 in South Carolina quite often became visit 4A, 4B, and sometimes even 4C. And I think research has confirmed this many times that the typical number of appointments for a conventional denture process is closer to 6 to 8. One university showed really 8 to 10. So they're tough, right? Try-ins are tough. Bite rims are tough. And if we can make this better, then let's do it. So I said this earlier, answer to number 1 question, do I have to change to digital? If you don't have a scanner, don't want to buy a scanner, not interested in that world, can you still do a digital denture? Absolutely. You send the impressions and the bites to the lab, they will digitize them, and you can take advantage of that workflow from there. But if you are ready to move, you have a scanner, you just want to move into the denture space, or you're thinking about a scanner because of dentures, how do you move into space, right? And what are your questions? Number 1 question I get, Can I put it in the mouth and wave it around and get dentures? Well, if you look at these 4 scans, you would say yes to that, right? Here is a couple of cases that the scans are pretty decent. And as a technician that does digital dentures, I would love to make dentures on these scans. But what I haven't said yet is that those scans that we're looking at are the most difficult, the most challenging, the most aggravating scans to take. I don't care whose scanner it is. It is a hard scan. So much so that I do not typically teach scanning intraorally edentulous arches, right? If somebody wants to do it, I can help you, but it's going to take a lot of practice. It is a very hard scan to take because of all the variability, because the way the cameras are looking for hard tissue. And so we teach a whole different workflow. We used to worry about the accuracy of the scanners. We don't worry about that anymore. There's enough research now that we're comfortable with the accuracy, but it now just becomes a matter of technique. So the number one expert, in my opinion, in the market out there today is a Dr. LaRusso, teaches at a dental school in Italy, and he's done most of the groundbreaking research, or has done it for a long time, on edentulous scanning, primarily with the Trio scanner, but I've seen him use other scanners as well. He's even invented these little retractors, right, that kind of help solve one of the problems we have when we're trying to scan a dentulous tissue, and that is how to hold everything else out of the way so that we get a stable scan. And that helps, but it's still a very challenging scan. There's a booklet he did. You can, Google that, Google LaRusso, a dentulous scan strategy, and you'll find that booklet and you'll see, what he thinks is the right way to do it. And primarily, again, centered around the trios, but follow the same path for most every other scanner if we want to try it. And I've worked with residents at Chapel Hill that are pretty good at it, and it's okay. But I'll tell you one thing, the dentists that are able to accomplish the intraoral scan, and we make a prototype denture and they put it in, every time I've done that, they've said it doesn't fit great. So we're going to do a wash impression in it and do a final denture. When we start from a wash impression, we don't have that very often at all. So that's why this study caught our attention, right? This is just another one of those denture fit studies. The denture on the left is a traditionally processed acrylic denture. The one on the right is a traditionally digital fabricated denture from an intraoral scan. The one in the middle is a digital denture fabricated from a scan of a wash impression. And it's clear that which ones fit better, right? And why is that? Well, scanning soft tissue is hard, right? And you can see the yellow in the palette. It's just hard. And so we don't get 100% accuracy. Scanning an impression wash, we've already gone through mucocompression, right? It's a static thing. And the scanners are amazingly easy and accurate when we're scanning impression material. So it's the absolute preferred way to go, right? Is do some sort of wash impression and scan that with your wand and send that scan to the laboratory, clean the denture out, give it back to the patient, right? So we're going to talk about these workflows, right? And how we do this. The first one is, we call it the reference denture workflow. And it is using the patient's existing denture as our preliminary impression tray. So we're taking a heavy bodied, light bodied wash impression in these dentures. We're taking a bite between these two dentures. We're then scanning that data with an intraoral wand outside the mouth. We clean up the dentures, give it back to the patient, and out the door they go unscathed. And all the lab needs are those 3 scans: scan of the upper impression, scan of the lower impression, scan of the bite. The laboratory is going to take that data and they're going to design and fabricate a functional try-in. I call these prototype dentures. I don't call them try-ins anymore. They could be monolithic like this. That's just easy and quick for labs. But patients struggle with that, right? Aesthetically. And so, but they could be pink, right? I tell labs and doctors, if you're struggling with the prototype and having a hard time explaining to the patient that it ain't about the look, it's about what we're going to learn in this prototype, just go ahead and print the pink one and let that be your try-in prototype. And if all's good, then you're done, right? It's a 2-appointment denture. But I want to do a prototype step because, wash impression, there could be nuances of the scan that might be different. But I'll say this about the reference denture. The reference denture is going to account for 60 to 80% of your denture patients, right? Demographics have told us that of all the patients in the chair getting a new denture, 6 to 8 out of every 10 have an old denture. And that's great because that is a wonderful starting point for us, right? It's the easiest impression you're going to take this week. It's an easy to get a bite. You've got everything you need. The patient can help you. It's comfortable for them. So, this is why the number one reason that it's successful. Number one, it's easy for the patient, easy for the dentist. The records are simple. And so think of this as your preliminary impression tray. But the data that the scanner captures gives the lab even higher level of accurate data so that we can do that setup. So when they designed that second appointment denture, that prototype, right, we had all the data of that preliminary denture. We know where her teeth were. We know where the midline, the incisal ledge, the buccal quarter, occlusal plane, all that's data that you just don't have with a bite rim most of the time. So we have it here, and it was easy for you to obtain. So we put the try-in in the mouth. Right. And I can tell you just from experience and knowing that there's over 1 million of these done now of just one material because they're tracked so well. And that doesn't count for all the competitors. So this is not a new process. And so we can tell you that when you start with reference denture data, 3 or 4 out of every 5 are going to be so close in this second appointment, you're going to wish it was a final denture. And I know this because I've had many labs tell me this. And they said, we just got tired of the phone calls from the dentist saying, hey, this tooth colored denture you sent me was great. Bite was pretty good. I adjusted 1-2 spots. Everything else fit was amazing. What do I do now? I wish that would have been the final denture. I would have delivered it. So these labs have said, you know what? We're not going to print the prototype in tooth color anymore. We just go ahead and print the final. And we're going to send you that. And because the reference denture data is so good, you have a very high probability of delivering that denture on the second appointment. But what if it's not? What if the bite's off? What if the midline's off? What if it doesn't fit good? Well, the coolest thing about the prototype is that becomes the best set of custom trays and bite rims you've ever used, right? Because they're going to be close, right? But all we got to do to fix them is take a wash impression if need be, tap, grind on the occlusion to get the bite right, and take a new bite registration. We're so confident in this workflow that we just pretty much guarantee that, look, if you do that, the next appointment, you're going to deliver it. So that's a 3 appointment denture. I will go to 4 sometimes because what I like to do, if we put these prototypes in and the patient has any doubts at all, hey, look, go home. This material we're using, even if it's a tooth collar, you can wear it for 3 years if you want to. It's that strong. And wear it for a few days and let it settle in, and then come back and we'll make any adjustments and do that. So this is what it looks like. I advocate a heavy-bodied polyvinyl siloxane around the border. We go in the mouth and do border molding movements, and then we put a light-bodied wash on top of that border and in the palate, and go back in and do border molding movements again. And so here's a video snippet of one that was done at the Dentsply Academy. This was Dr. DeCoke from Chapel Hill. Brought a patient in that was wearing an old set of dentures. Overall, okay. They looked okay. Just weren't staying in very well. And he wanted to show a little bit more tooth. But she's doing all the things that a prosthodontist does, right? We're checking the interpupil line. We're checking the occlusal plane. But you can see here now, it's put a little adhesive on his denture and ready to put that heavy body. Again, I like a heavy bodied, fast set. She's going in the mouth and doing those border molding movements. Right. And there's various ways to do this, right? Whatever method you like to do, some sort of border molding movements. Once that's done, right, trims it up a little bit, adds a little bit more adhesive, comes back and puts a light bodied and goes back in the mouth and do those border molding movements again. Now, this is a snippet of this video. It's only about 1 minute long. It's a 15-minute video that I'm going to give you access to at the end. So I'm going to give you a link to a handout folder. If you want to go get it, that video sits in there, and you can watch the entirety of it, because they list all the materials they used here. And of course, it's not sped up like this one is. And you see the whole process, and you see how easy it is. But it's a great, what did they say about this step? Because all the steps are right here in this video. So you're going to have that at the end. You can see how fast the scan goes. It's not hard. Even though it is sped up, you can tell it's a pretty quick scan. I mean, I've seen this done in 1.5 minutes. So I tell folks all the time, if it takes you longer than 5 minutes, you need to stop, delete the scan, and start over. And I would expect and hope that we could do both upper and lower and bite scans outside the mouth in our hands in 5 to 8 minutes without any problem. Pretty simple scanning. All scanners are pretty good at this. Some you have to use a little bit differently, and we'll talk about that, but they all work. So that's the reference denture digital workflow. I'll show it to you just in some still images here. So I like to take a dot on the chin and nose to measure where the patient is vertical, because we want to go back when we put these dentures in the mouth with this impression material, make sure that we're not opening the bite more than a millimeter or so. You know, if we're opening at 3 millimeters, then we've got too much impression material. We want to take it out and start over. But you can see the border molding movements and how well we're capturing the muscle connections. So heavy bodied in, go in the mouth, border molding movements. This is Kikuchi's method that I like. It's have the patient ooh, ee, ah, tongue out, left and right, close, swallow a couple of times. It just really captures those really well. Don't have a scanner, send it to the lab. They'll put it in the box scanner. But if you have a scanner, you obviously want to scan that in your office. And this is what the lab sees. From the scans of the wash impression in those patients' dentures, the laboratory software turns it into 2 models ready to set some teeth virtually. But the purple that you see there, that's the patient's existing denture, right? So we've got a guide. Another case we did, had to build up the heels. These dentures were really worn, but heavy bodied, border molding, light bodied, border molding, take a bite where she was. If we're going to open the bite 1 or 2 millimeters, you can take the bite in centric and just tell the lab, because we have the virtual articulator tools. We can do that. If you need to open the bite more than 3 millimeters, you're probably going to want to take that open bite to help the lab so arc of opening stays normal. Now, here's another big win, because there's a misconception out there that in this workflow, you need to scan the entirety of the denture, and you do not. For a reference denture impression, all we need is intaglio, borders, and buccal surface. If you see the sort of middle picture in the bottom, I didn't scan the palate at all. Don't need that data, don't want that data, don't want to waste time trying to capture that data and slowing my scanner down. So intaglio, borders, buccal surface. I use powder only when I have to, and I only have to when it's a highly reflective surface. Like this is Emperor gum, so it's a very shiny impression material. I like polyvinyls. Most of them are matte, and they scan easily without having to put any powder. So this is a quick snippet of, notice that the dentist has trimmed away the impression material. You want to see all the buccal surfaces, right? Number one, the intraoral scanner needs to see the buccal surface to do the bite registration. Number two, your lab guy needs to see the buccal surfaces so he knows where everything is: occlusal plane, midline, buccal quarter, all that data. So we want to see the teeth. So those 3 scans go to the lab. The lab's going to design and build, print, mill this prototype. That goes back to the doctor for the second appointment. So second appointment, again, I like the prototype. It's easy, it's fast. I don't have to print teeth, print base, glue anything together. And if it's me, I print them all out of A2. But I understand patients, and if we just have the conversation ahead of time and explain what we're doing, I think patients will understand, especially if they've been through a denture treatment before, and you ask them to remember their wax try-in and what they remember and all the things about don't bite too hard, all that stuff. And we say to them, look, this is not how your denture is going to look, but this is a test drive denture. You can chew on it. You go eat 3 weeks worth of meals and then come back and tell me right before you make the decision. And labs can do extra work. We can paint pink on it to make it look a little better. But this is the type of denture I would use for an immediate denture, because again, it's easy, it's quick. It's just as strong as the pink. But for an immediate denture where the patient's going to be wearing it for a long time, I would use one of the extra materials on the market to give the gingiva some color, right? Whether it's Easy Gum or Annex Gum or GC Gradia, any of the pink stains to, just for the benefit of the patient. But normal dentures, look, it isn't about the color. It isn't about the statics. It's about how it fits and feels and how it functions. So the data's better. But look at the adhesion we're getting here, right? I wished I had recorded the patient's eyebrows and the dentist eyebrows, because nobody can believe it, how well this thing is staying in. I was helping a dentist yesterday and helped him with the design, and went and printed the denture. And the assistant told me this morning that she said, I couldn't get it out. I had to get the dentist in there to help me get it out. And that's just a computer telling part A to fit part B to exactly 100 microns. That's what you gain with digital. So here's a continuation of that video. It's just a brief summary of what we're doing on the second appointment. We're doing what we always do with a denture delivery, right? We're checking the fit, any high spots that we can grind them down. Once we have it ground down, and if it didn't fit, then we're going to grind down the spots. We're going to take a new wash impression. Then we're going to check the bite, right? We're going to check the midline and size of ledge. We're going to check the buccal quarter, all the things that we would normally check to make sure that everything is as it should be with tooth position and bite. And when it's not, then we just make adjustments. So again, no more Bunsen burners and wax spatulas. I'm thinking about softening wax and moving teeth. You do what you do every day. You get out your articulating paper and your burr, and you tap, tap, grind, grind, right? And you get that bite dialed in like you do every day with any other restoration or, equilibration. And then you just take a new bite registration. And so your armamentarium has changed, right? We need articulation paper, an e-cutter, a Sharpie, bite registration material, and maybe impression material, right? And so we always check fit first. And if it's not, then we just take a new wash impression, right? Same thing as we did in the initial phase. Once the impression's in there, then we're going to check the teeth, right? Occlusal plane, buccal quarter, midline, all the things. You can cut on it, you can draw on it, you can add wax or composite to it, right? Just to have at it to get the teeth where they need to be for the patient. And again, starting from a reference denture, you won't be doing much of this, right? It's just good data. So this denture is usually very close. Video. And so what we're doing is we're taking a printed prototype and we're calling it a try-in denture or a prototype, but it's really just a real sophisticated bite rim. And you treat it as such. I remember a dentist calling once and saying, we missed the bite really bad. The right side is really high. I'm going to have to grind all these teeth down. No big deal. Grind them all the way down and take a new bite registration. That's all we need to do. And with this new data, we have the cool technology today that we can scan this new data, bring it into our software, and redesign the denture almost automatically because the software analyzes our original setup. It analyzes your new bite and impression data and merges the two together for us. And we just tweak it and dial it in. Technology is grand, guys. It really is. And so I think we've eliminated bite rims and custom trays because this becomes that for us. And it's a lot easier tool to use. So whatever changes you made, like the upper one, the only thing was off was the bite. So ground and took a new bite reg. The bottom case, the lower didn't fit as well as we wanted. So we did a wash impression there and we took a new bite after adjusting the occlusion. The upper we left completely alone. So all we had to do is go pull the upper file and print the pink and teeth and put them together. But the lower we did over. So this is what happens in the lab from those changes. So this is that I think is that lower case. You can see the impression material. You can see where Dr. Clark had ground on the molar and got it, she got it dialed into where her bite was. Then my software brings in the original design in this new space. And the software figures all that out. And so I said, that's pretty darn close. And what I'm going to do is use all the tools, the articulation tools, the equilibration tools to make sure that we dial it in. So we were able to bring in the original setup, the original mold, right back into this new alignment just based on that impression and bite data she gave me. And that's the beauty of technology. It just requires a lot less work these days, but it's grand. And the patient puts it in and it didn't like a wax try-in, right? Sometimes we put that wax try-in and the patient signs off on it. And then we process the denture and they say, I don't like this. It is a little different, right? Wax to acrylic, but here it's the same denture. So they won't say that anymore. So we're delivering in the third appointment. It's 4 appointments if we send it home with them for a day or 2 or 3 or whatever, but 3 appointments and then sometimes 2 because if it's all good on that second appointment and we had our lab print the pink and white one, then we really don't need to do anything but say, thank you very much. And it happens. So the reference denture is my favorite. Number one, it's the biggest piece of the pie, more patients, and that's where we can start. But, everybody says, what about the guy that shows up like Fred here, no teeth, no denture? And so when you have that situation, you have to do a little bit of analog, right? And it could be exactly like we've always done it, right? You could get the alginate or the alginate substitute out and take a traditional impression. And your lab guy could pour some models, make some base plates and bite rims, right? That's 101. That's what we've always done. The difference becomes that you can choose not to use the alginate because you have an intraoral scanner and because all we need to fabricate at this step is base plates. This is the one circumstance where I'll say use your scanner. get in there and scan the upper and scan the lower. I don't need a bite. Just scan the upper, scan the lower. All I'm going to use those scans for is to digitally design and fabricate these base plates. I can do that better than just a thermoplastic or a suck down base plate. This is a much better base plate. And the scans don't have to be 100% accurate for this to work because we're going to do a wash impression in it. So if you can get 60, 70, 80% of the data, I'm okay with that, right? And we'll design the base plate, we'll print them, we'll put tissue stops, put holes. And base plates today mean something different to me than they used to. A base plate used to be a stabilized platform to set teeth on, but today a base plate is an impression tray for me. It's an impression tray without a handle. So we're going to go into this second appointment with these pre-printed or prefabricated base plates. And guess what we're going to do? Heavy bodied around the border molding movements. Light body wash on top, border molding movements. We're going to do the same thing on the lower. We're going to remount the bite rims, and we're going to fabricate the bite or melt. And this is where the analog comes back in, right? You're going to have to get back into your mindset of, carving and shaping and melting and getting that wax rim down to where it needs to be, and then snapping the bite ridge between them. But the impression is the same as a reference denture, no different, right? The bite rim is still a challenge, no doubt about it. But that's where we are if the guy didn't have an old denture to work with. But if you noticed yet, we did this in one appointment. I took the upper impression, low impression, final impressions now, and the bite all in one appointment. There's no sense in spreading this out, right? Let's get this thing fabricated in a quick way. So we've now got our final records that can go to the lab, and they can be scanned in the office with the intraoral scanner. Say that again, that can be scanned with your intraoral scanner with the same success as we scan reference dentures. Our scanners are amazing when they're looking at something that's hard. So use your scanner, scan the upper, scan the lower. Now, if your lab's close by, then just send it to them, let them put it in the lab scanner so you can let the patient go. But from that scan, right, the labs can make the prototypes. And in this case, Dr. Wendy likes the monolithic. So you can see what we've done here, right? We had to do some grinding. We had to do an impression wash. But what are we doing with these prototypes? We're doing what we do with any try-in, right? Are the teeth in the right spot? But we're doing more, right? Does it fit good? Does it feel good? And there was just a misscan or something. And one side of the lower was just also, Dr. Clark just took a new wash impression. And, then we dialed in the bite, took a new bite registration. And that goes back to the lab, and that data is used to, again, the same way as before, get the teeth in the right position and print the final. So this is a 4-appointment denture, right? I just took something that's typically 8 appointments and made it 4 appointments. And that's pretty predictable, guys. I would almost guarantee it that we could do that in 4 appointments with any of you. It's not a hard workflow. So Fred was a happy camper. Right. This was Fred's 7th set of dentures in his life. Fred had a very serious problem of losing dentures. He said he'd been without his last set for about 1.5 years, and he couldn't remember what happened to him. And I said, well, Fred, here's the one thing we'll be able to do today is I'm going to send you out here with 2 sets, right? So you'll have your backup plan right away. But just in case you lose those 2, all you got to do is call Dr. Clark, and she calls me, and we push the print button on the printer, and boom, you've got another set. So Fred was happy. He said they fit better than any denture he'd ever worn. And of course, Dr. Clark is a great prosthodontist. So all the records were good. And, she did a super job of getting a smile line right, and very, very successful case. The last workflow is the immediate dentures. And this is where I tell you guys with intraoral scanners that you should never take a traditional impression for immediate dentures again. Intraoral scanners struggle with a dentulous tissue, but if there's hard tissue in there, then that's what they were built to do, is scan hard tissue. So if there's teeth, right, they'll see a tooth in a stretch of tissue, and they'll see another tooth, and they actually do a pretty decent job. So we want to use our intraoral scanners on immediate dentures. Scan the upper, scan the lower, scan the bite. Send those 3 scans to the lab, and the lab's going to use what we call a virtual extraction, right? We're not going to print the model and whack the teeth off with a burr. We're going to take those scans as they are. We're going to use a virtual extraction tool to remove the teeth. And what that does for us is that it gives us a bit of data we've never had before. And that bit of data are the extracted teeth. As we're doing the virtual setup, I can turn the extracted teeth on and off at my pleasure to see, okay, where was the buccal corridor? Where was the occlusal plane? Where was the midline? Where was his incisal edge? All that data is there for me to look at as we're setting that arch. That is data we've never had before on immediate denture cases. So it's a very valuable piece of data that makes immediate dentures go much better. In my history, most immediate dentures would come back and say the teeth are too far forward, right? It's because we're setting to bone, not to where the patient's teeth used to be. So this is an amazing tool that you want to take advantage of and always use digital. This, Dr. Clark and I have not done immediate denture traditionally in 3.5 years. It is now part of the curriculum at UNC. Second year students now learn to do immediate dentures digitally instead of the old school way because it's just better data. And when we have that data, it's another one of Dr. DeCoke's case, right? And here's another tip. Take a photograph, right? Chin to forehead, send that along with your scans. This is what the lab will do with that, right? They will overlay that photograph to their setup so we can actually see. And I tell offices to take 2 photographs. Take a high smile, patient smiling as big as they can, whether it's in their immediate before the extraction, before we even take the scans, whether it's bite rim, whether it's old denture, high smile, and then a relaxed lip. And we're going to look at both those photographs as we're setting teeth, because that, again, is a valuable piece of data. And it made this pretty much a 3-appointment immediate with a long healing period with this guy. Because what happens after he's healed up, right? We deliver the immediate denture, we extract the teeth, deliver the immediate with a soft liner, let the patient heal. At the end of healing, we take the soft liner out, and what do we put in the immediate denture? Heavy bodied impression material around the border molding movements, light bodied border molding movements, the same as a reference denture, right? We take it out and we scan it, right? And maybe we've made some occlusal adjustments, whatnot, then we scan that as well. And that goes back to the lab for the fabrication of the final. Wonderful, wonderful, very predictable, very accurate workflow. Other things labs are doing, partials, yes, flipper partials. Why not? It's twice as strong as acrylic. I would like to use it. We can add a wrought wire class to it. We don't have a flexible resonant we can print yet. Of course, there are flexible partials out there, but all those are either milled or injected. But printing is where the world's going, and there are several players coming onto the market with flexible printed resins real soon. Copy denture is a workflow that you need to be comfortable with, right? Because the copy denture workflow is just an example of partials. Yeah, if you got metal partial, yeah, scan it. Right? If you got teeth, scan it. Copy dentures is for that patient that says, yeah, I'll take a new denture, but it's got to be just like this denture. Or the patient says, I sure would like to have a backup denture. So a copy denture is different from a reference denture. A copy denture, even though we can do a wash impression, is where we're not going to change the teeth. It's a different tool in the lab software, and we actually click a button that says copy denture. And what that tool does for us is that it separates the teeth from the base. So it is an exact replication of the teeth on the existing denture, even if they're old and worn out like this, because this is what that patient wanted. She said, I don't want anything new or different. I want this one, but I would like it to fit better. So wash impression and use the copy denture workflow. The main difference with the copy denture workflow is that is the 360 scan. Whether it has a wash impression or not, you have to scan that denture 360. With a reference denture, we don't scan the palatal side. We just scan the intaglio, borders, and buccal surface. Implants, again, yeah, if it's that strong, why would I not? So all the overdentures, locators, conus, any of the overdenture type, if I can use a denture base that's 2 to 3 times stronger than anything I've ever used before, why would I not want to use it for this? Been validated with all the pickup materials. Cold cure acrylic sticks to it. So yes, it's repairable, and we can use it to pick up attachments. And so all the overdentures I do. And then these things, the prototypes, the temporaries for all on X cases, great material for that. So milled PMMAs have been kind of the standard for these things for a long time, but printing is so much easier and faster. And now that we have these stronger resins, it's my go-to. And I actually like these new polymers for that because they're not quite as brittle as some other things we've been using. So I typically design them and print them out monolithically and then just paint a little pink on it. And I'll send 2, right? Why not? Because it's just as easy to copy and paste and print 2 in the beginning as it is to print 1. So you always got a backup. And then this last use, this is a product, and there are multiple products like this on the market, but it basically says we're going to take some really sophisticated scan posts and we're going to scan in the mouth. Because we've got this many scan posts, we're going to capture the tissue in between the scan posts. And from these scans, we're going to be able to get a 3D selective laser melting. It's a printing of titanium bar. And then we're going to get a core file of that bar where we can design this overlay. And in this particular picture, the overlay is a printed denture. And then the bar's coming in, and we're going to glue the bar inside the denture. And that's the final restoration. And we did it from a scan. We did not have to do a verification appointment. Same file, we could do a zirconia overlay, right? And I want you to watch how well these bars fit. And it's all due to the accuracy of our scanners today and the accuracy of those scan posts. And whether it's printed denture base or whether it's zirconia, we can get this kind of fit. And this is now a really big trend, is that everybody's now gone back to metal reinforced all-on-X restorations. The only thing left for this technician to do is glue these two things together, and that's the final restoration. And that just blows me away that we're doing that. This is a case I did with Dr. DeCoke. So you can see the prototyping, you can see that she did a wash impression. But then once we had the prototyping finished, then she did those scans, and our next appointment was the final. We took an all-on-X workflow that was typically 6 to 7 appointments and did it in 4. Very simply, very easily, just by doing good prototyping and having great scans and great technology in our scanners. So let me summarize as we're getting to the end here. You want to scan some sort of wash impression, whether it's in a base plate or a reference denture. I want you to use a heavy bodied on the border, light bodied wash, and on a reference denture, taglio borders, buccal surface. Understand your scanner. What do I mean by that? Well, I'll give you an example. When I pick up a Trios and I'm scanning a wash impression in a denture, I start in the taglio. When I pick up a prime scan and I'm scanning a reference denture, I start on the buccal surface of the teeth. And it's simply because the scanners seem to do better when we do that. I don't know why, the algorithms, whatever, but that's what I mean. Just to understand your scanner and what works best. In the handout folder you're going to get, there are also PDF scan strategies for this thing. But the scanning, we've been through that, what that looks like. Here are a few little bullet points about the 3 major players on the setting it up and how you set it up. And take a quick picture of that if you have one of these 3 scanners. So it'll tell you how, when you turn it on, what button to push, and a couple of tips on how to use it best. And I like all these. I'm trained in all these. I teach folks on how to use all these, and I don't have a problem with any of them. And so there's your resource folder. That QR code on the left will take you to an email form. Just fill it out, and it's all automatic Google Drive. It's such a big file. It's a file folder. It's got about 5 gigs of data in it. So if I gave you a direct link to the folder, you would never get it downloaded on your phone. So the easiest way is to just get this email. And when you get the email, there'll be a link in it that takes you right to it. So just fill out the form, you'll get it. And it'll have all these things and more in it. So all the materials I've mentioned as far as clinical videos, how-to videos, scanning guides, checklists, all the things are in there. And the other QR code is my contact.